So welcome to the Excellence in Full Denture Technology webinar. It is being presented by Dennis Urban, CDT, and VP of Education and Training. Dennis Urban has over 40 years of experience in dental technology field, including lab management, manufacturing, technical training, sales and marketing, product development, quality assurance, writing and lecturing. Dennis has been an eminent lecturer to dentists and technicians worldwide since 1985. He is also a formal dental laboratory owner. His lectures and training span many areas of dental technology, including digital technology, removables, implant dentures, shade communication, and occlusion. His technical articles have been published in numerous dental publications in the US, Canada, and Europe. Dennis now serves as the chair of the National Board of Certification in Dental Technology and is on the advisory board for IDT Magazine. And with that, it is my pleasure to say, take it away, Dennis.
All right. Thanks, Jessica. Are you sure you're talking about the right person? I feel like I sound old with all that, all those years behind me, but I don't feel old. I don't feel old, but thank you everybody for joining us tonight. And I hope everybody's excited about full denture technology because we've come a long way. And this is my, I guess, 40 going on 42 years in the dental laboratory industry. And I've had the opportunity to travel the world and lecture. And tonight we're going to talk about a lot of things I've been successful with over the years. And we'll talk about, well, I'll go through the list in a minute, but we'll talk about analog type of traditional type of dentures with successful outcomes. And then we'll get into some of the new digital aspects of it also. But again, over 40 years of dental technology. This is me in Little Italy in New York at a San Gennaro festival feast there. And hopefully we can do that quite soon again, you know, when we're able to get together again. And then, you know, I've had, like I said, I had the opportunity to travel and learn worldwide since 1985. And I love the removable technology field. And today we're going to talk about what's been successful for me. And if there's any technical difficulties along the way, please let me know or let Jessica know. So hopefully you can see the screen nice and clear here. And I know we had some problems with a little black spot on the screen earlier, but hopefully that doesn't affect the presentation. But we come a long way with denture technology. As you can see here, on the upper left, those are George Washington's dentures, and they were made from lead, whalebone, and a bunch of other things there. So, and then you know, on the right-hand side, on the bottom, we see a denture that was made from a vulcanite rubber material a long time ago. So not too aesthetic, you know, but the vulcanite fit well, but not too aesthetic. And I don't know how comfortable everything else was, but we've come a long way with materials. You know, so we're going to talk about some of those materials tonight. You know, denture-based acrylics and advancements in denture-based acrylics, denture teeth, digital dentures, some techniques we're going to show that makes it a little bit easier, a little more accurate, and a little more predictable in making full dentures. So, you know, like I mentioned earlier, we've come a long way with acrylics. You know, now we can have these high-impact acrylics that look like natural gingiva. And these are some of the dentures I've made here. And this is just showing some of the denture-based staining that was done and the aesthetics that can be utilized with the latest denture teeth, which look like crowns. They look natural. And some of the denture-based stains you can do to mimic the natural gingiva of the patient. And this is characterized wax up. I used various different waxes to mimic the natural gingiva of a patient also with wax try-ins. And you can see here just as some of the striations and veins and everything looks so natural for a try-in. But, you know, we like to do this so the patient can see what that denture is going to look like when it's finished. Here's a real dramatic denture-based staining here. And these are with Physiodent's teeth here. So look how natural that looks for a denture. Beautiful case. And this is another one of my wax ups. So we've come pretty far with materials, and these teeth are beautiful too. I mean, everything looks so natural, and that's people don't want to look like they're wearing dentures. And this is what we're trying to achieve: function and aesthetics. And with digital technology, we've come so far now. So now we can accurately print or mill a denture, which is the accuracy and aesthetics that have really come a long way, especially in the last couple of years. So more people need dentures than ever before, and the industry predicts tremendous growth now through 2050. And this is a quote by Dr. Stephen Wagner, who's a prosthodontist. And he says, you know, experienced denture technicians are the guides for dentists and patient success in denture prosthesis. So we work together and collaborate with the clinicians to get that success. And one of the meetings I was at last year at the Seattle Study Group meeting, Dr. Christian Coachman came out with these words, and I was taken by surprise. He said, professionals who understand dentures are the ones who understand smile design. So if you look at what we go through, especially filling the oral cavity with a full upper and full lower denture, we have over 40 millimeters of intraocclusal space that we have to fill and make it look natural and functional. So sometimes it's difficult. But if we understand dentures and occlusion and smile design, we can do this with success and every time after time. So, but we do have growing edentalism in this country, and more than 36 million Americans have no teeth, and 90% of those have dentures. But 90% of denture patients are unhappy with the fit of their dentures. So we're going to address that tonight and give you a more predictable outcome with these types of cases. And some of the dental challenges for the clinician, dissatisfied, frustrated patients, difficult to provide a good fitting denture, long-term turnaround time, and significant chair time and adjustments. So we're going to try to raise that comfort level of the clinician tonight with less adjustments. And here's one of the surveys that was done a few years back, and it said 52.8% of all United States labs surveyed claimed they had an increase in full denture cases in the last 5 years. And that's pretty good. If you go around the country to dental laboratories, most of the laboratories who are doing removals have had an increase in business. And another survey, there was dentists asked, how many would like to increase their full denture business, and surprisingly, it was only 46%. And some of the reasons behind that was because of excessive chair time, adjustments, possibly remakes, adjusting occlusion, sore spots, and it was taking too much time in the operatory. So that was one of the reasons why I think we got this kind of feedback. And then we talk about partial denture cases. Almost 53% had an increase in partial denture cases also in the last 5 years. That includes metal-free partials and metal partials. So that was pretty interesting. And the dentists who would like to increase their partial denture business was over 65%. So the clinicians felt there was less adjustments with partial dentures than there were with full dentures. So the first thing we have to do, when we're looking at these types of cases, is address communication. We need to have good communication and good case planning and proper case planning with the proper protocol. So between the dentist, the technician, and the patient, we have to address and meet the patient's expectations also. And if we cannot meet those expectations, we have to be prepared to come up with an alternative solution. So we have all these means of communications at our fingertips all around the world here, with all the latest technology, but sometimes we just can't plan a case correctly, and it's very important that we do this. And anything from, impressions to the final outcome and everything in between, we need to collaborate to make a successful case. So the communication from the dentist, we count on your clinical knowledge and training and the assessment of the patient, appropriate treatment planning, detailed information on the work authorization form. This is really important. And, we need that information. I'll talk about that a little bit more later on when we talk about occlusion. And we like to get digital photography also. That really helps us because we really want it to feel like we have that patient at the bench with us so we can do a proper case and just take all the information that you give us and apply it to a successful case. And of course, correct materials and high-end materials and materials that are going to be consistent and best for the patient. And communication from the certified dental technician depend on our technical expertise and knowledge and procedures and materials, and the appropriate feedback to you on impressions, bites, shades, etc. So, I always tell our technicians, if you see something on the onset of the case, stop the case, call the doctor, and let's get it right. So I think most of the calls we make phone calls on are impressions, and we want a good accurate impression. And secondly is bite registration. So, we have, I have no problem calling the doctor and saying, let's maybe do this over again, take a new bite or a new impression. This way, we don't have to worry about remakes. So we would like to do the case planning with you, if it's an implant case, with you and your oral surgeon. And of course, we need all the technical digital photography and collaboration on these cases here. And the main focus is on patient acceptance with these types of cases. So let's look at some of the problems with full dentures. Let's go to the negative side first, and then we're going to go to the positive side. But over the years, if they're not made correctly, and the right materials aren't used, and if a laboratory follows through on a bad impression, there's compromised stability. And poor neuromuscular coordination with occlusion. We have to make sure we have the right occlusal scheme, so we'll talk about occlusal schemes in a little while, and also the low tolerance of mucosal tissue for removable acrylic bases with sore spots and sometimes allergic reactions, and the patient's desire for more stability and comfort. So the patient wants that stability and comfort, especially on a lower denture. And the comfort level of the dentist is compromised due to the excessive chair time. So this is what we're going to try to eliminate. And when we get into the digital denture aspect of it, we're really going to eliminate a lot. So we'll talk about the consistent outcomes with digital dentures also later on. So we're going to go through this presentation. After I go through the traditional method, I'm going to pop up a slide. It's going to have questions on it. We have a little ways to go here, and then we'll stop the questions and take a little break, and then we'll come back and we're going to talk about digital dentures. But the goals of the final outcome: we want to create natural aesthetics, enhance facial appearance, compensate for that lost soft tissue, and enhance the function with the right occlusal scheme, whether it be physiological centric occlusion or possibly lingualized occlusion. And most of the time, I'm going to be using lingualized occlusion is with implant cases or implant overdenture cases or hybrid type cases. We want to create a denture with longevity, impact resistance, and bacteria resistance. And we're going to talk a little bit more about that when we get the materials, especially the acrylics that are out on the market. And we want to eliminate and reduce the adjustments on occlusion and sore spots. And some of the common mistakes in fabricating full denture is poor treatment planning, distorted impressions, inaccurate master models, insufficient occlusal records. So I'm going to spend a lot of time on occlusal records in a little while also, and the poor choice of materials. So I never like to sacrifice quality on poor choice of materials. Especially with denture teeth and acrylic and things like that. So never want to compromise on those types of things. So let's talk about getting the patient ready for a denture, getting the exam checklist, getting the patient in chair and just talking to them about, we have to figure out the physiological factors, the anatomical factors, the functional factors, and the aesthetic factors. So patient expectations. Dentists should meet the mind of the patient when they're making a denture before they meet the mouth. So find out what's going on with these patients, if they had a lot of trouble in the past and why they're having so much trouble on the removable prosthesis. So I always recommend a preclinical interview, and sometimes I'm involved in these interviews too when I'm doing case planning with the clinician, and ask the patient, what are your specific concerns or limitations? How long have you been a dentulous? How many dentures have you had since your tooth loss? And how did you lose your teeth? And when was the last time your dentures were relined? So a lot of patients wear these dentures for 5, 10 years and do nothing. They never get them checked for occlusion or gum resorption. And then if it comes to a point where the patient is really having trouble, especially on a lower denture, well, we ask them, have you ever considered implants? Possibly an overdenture would be in the way to go. And also look at patient complaints, history of dentulism, the support they have with their dentures, the stability, retention. And then we have to look at the floor of the mouth and tongue room position, especially for a lower denture, because I see this a lot. I see there's just not enough room sometimes for the patient's tongue. And this is where the technician's know-how comes in creating a concavity in that lower denture on the lingual side so the patient's comfortable and rest their tongue in there. And when we do that, it almost acts like retention. That tongue lays in there, pushes down the denture, the lower denture, and you get better retention. So, we have to look at the ridge analysis on these types of things on the upper and on the lower also, and look at the tongue room. So a case like this on the right-hand side, there might be a little problem with tongue room. So we have to contour that final denture accordingly. And then we still have to look at border extensions, centriculation, VDO, phonetics, especially we'll talk about denture teeth and phonetics with lingual anatomy on denture teeth, aesthetics, occlusion, and the opposing dentition. So we want to make sure we have a nice working and balancing type of occlusion on these types of dentures so patients can chew and eat efficiently. Let's talk a little bit about best practices for full dentures. And this is the traditional way that we're talking about here, with probably about 5 visits from the patient to the operatory. And the first visit is the preliminary impression. I'm going to go through each one of these steps in a minute. The second visit is going to be your custom tray final impression. And then we'll come back to the laboratory and we'll make a bite registration or occlusal rim for you. And then we'll do a tooth setup and wax trying. And then once that's correct, everything looks great. we go to a final insertion, and then we'll process that in the lab for the 5th visit. And a visit can be eliminated if a functional impression is taken inside the occlusal base plate, and bite registration is taken at the 2nd visit. So you're taking a bite registration and an impression at the same time, and I'll show you what I mean by that in a minute. So let's talk about the first visit with the preliminary impression. So we want to get a nice accurate impression, and we really want to try to capture all the anatomical landmarks on these types of cases. You know, the habular notch, all the borders. This way, when we make that final that custom tray, it's going to be an accurate custom tray. So we want to get a good stock tray if you have, or and just make sure you capture all those anatomical landmarks in the impression. And a lot of this stuff might seem preliminary to you, or maybe just basic. But I love to go through the basics on full dentures when I'm talking about them, because that's what's going to lead to the success of the denture. So that preliminary impression is important. So we get that back in the laboratory, and this 2nd visit is going to be the custom tray impression. So, I'm going to talk a little bit about that in a second there when we talk about impressions. But even with the final impression, you want to capture all the anatomical landmarks, retromolar pads, habular notches, frenums, all the musculature. But we also need to do some correct border molding on these types of things. So I always go about 2 to 3 millimeters short of the border when I'm making my custom tray. This is going to allow you to border mold. And, the method I have had the most success with border molding is taking a heavy body or monophase material, putting a little adhesive on the borders of the tray, and putting that monophase or heavy body material on the borders, putting it in the patient's mouth, having them move their cheeks, get a good impression of the musculature and muscle attachments in the mouth, take it out, and then come over with like a medium body type of material, PVS material, and you'll get a nice accurate impression. Here's another tray. Here's an upper tray with a border short, 2 to 3 millimeters short of the border when I trimmed it. And what about tissue stops? Well, we got quite a few doctors who want tissue stops, and this is going to create room for the impression material. And as you can see here, we have 3 tissue stops here on the lower. And just want to make sure when you're taking that impression, just, yeah, you have tissue stops, but when you push it down, you don't want to compress the tissue either, because it's not going to be accurate. We're going to have to grind those indentations away, on the model. So on the impression when we pour the model. So it's important. And on the upper, it's really important I usually put 4 tissue stops on the upper, and I never put one near the papilla, because you're going to compress that papilla. I know this is off to the side, but it looks like it's impinging the papilla a little bit. So I would put 1, 2, 3, 4 tissue stops here, and then I would make my custom tray, and I'll give you room for the impression material. And of course, if there are undercuts, we want to block out those undercuts for you, so you don't have to worry about locking in that tray, especially on an undercut ridge. It's really important. And perforations, we have some doctors who ask for perforations, but you have to be careful with perforations also, because especially with PVS material, if you're using a light body material, it's going to run through those holes and run all over the place. So, I am not a big fan of perforated trays. That's just my personal preference here. So we're doing our border molding here. I'm going to add some adhesive on the borders here, putting some heavy body material around the borders, and I'm going to take a nice border molded impression. And you can also use compound. I know a lot of clinicians still using compound. There's nothing wrong with that. But I just find, I think it's a little bit easier to use the PVS material. And this is just an indication. This particular impression here, the doctor actually put some border molding in the post-dam area. And this could be detrimental sometimes too. If you have too much air in that area, it's really going to compress that soft tissue in the post-dam area. And it's going to create almost like a type of denture that's going to be actually forced out of the mouth. So when we make the final denture, because we're going to add a post-dam in there anyway for about 2 to 3 millimeters in the stone. So the combination of both sometimes could be detrimental. And like I mentioned earlier, if you want to cut out a visit, you can actually border mold. This is like a custom tray material with an occlusal rim on top. So what we do first is take a nice impression, border mold it, take a nice impression, and then take a bite registration. So it's going to eliminate a visit, so it's going to eliminate some chair time. But I think it's a great way to go. It's one of the most accurate ways to actually transfer that information to an articulator. And these are the master models with the functional tray and functional impression. And the bite registration using the functional impression with therapeutically designed bite rims is the most reliable way to transfer the oral situation to the articulator. And yes, we're going to have to make new base plates when we do our setup, but I'll show you how we do that later and still maintain the information that was given to us by the clinician. And some of the wax registration, bite registration alternatives is utilizing an existing denture for impressions and bite registrations. So if the existing denture is in good shape and the bite is not that far off, or maybe there's not that many issues on the bite registration, utilize that denture. Take a wash impression. Might have to border mold it because the patient might have had recession, or maybe the dentures weren't made correctly to begin with. But take a nice wash impression, and then you can take a nice bite registration. And when we get to the digital world, we'll talk about that later, that can be scanned and sent over to us at the lab. Again, take a wash impression and a bite registration at the same time with existing dentures. Let's talk about the final impression. There's a lot of impression materials out there, so whatever you're getting the most success with, I would say continue using. If you're not getting success, you can always contact us at the laboratory. We have lunch and learns on impression taking. I have a seminar on that. Even the manufacturers out there who make impression materials, they support these lunch and learns and educational programs also. So I want to make sure you get a nice final impression with that custom tray. And here we see this is a nice impression. We have everything we need here, all the anatomical landmarks. We're going to pour these up, and it's going to be a great working model for an upper and lower denture. Something like this, you have pressure areas with probable overextension of the borders here. As you can see here, I see some tray material coming through here, loss of detail from excess saliva. And so if I got this impression, I would look at this and say, I'm not crazy about this at all. And I'll probably pour it up and maybe make a new custom tray. And also, if you look at this here, this is a real heavy body material. I don't know if it's an infragram type of material, but when you have a heavy body material on an upper impression, and I've been doing this for 40 years and I've seen this, you get compression on the tissue. And a lot of times it's not going to fit correctly. And that's where you get instability, and that's where you get sore spots. So I recommend like a medium body impression material. If you're doing a reline, if there's an existing denture and there's not much resorption, then you can use a lighter body material. But I recommend maybe a medium body PVS material. And how about this impression? This is an actual impression. Don't laugh, but this is what I got at the laboratory. And I felt so bad for this patient. I mean, this patient must have been gagging so badly or laying back in the operatory chair while they're getting this impression taken. And not only that, because you can see here, you can see the overextensions here. This wasn't even border molded. So all that material running down the patient's throat, and I wouldn't use this because I don't think it's that accurate. With this, you can see a better photo of it here. Really not an accurate impression on the anterior region of this region, but we got plenty of material going down the patient's throat. Got a beautiful impression of the patient's throat there, but that's not going to do us any good. I really feel bad for the patient. So when I got this to the lab, and this is probably about 8-9 years ago, I got this. It had to be one of the most unusual impressions I have ever seen in my career. So that's why I took some photos of it. But here you see, this is a nice impression, captured all the anatomical landmarks in this particular case here. This is that functional impression with the custom tray and bite registration. This is a beautiful case, beautiful impression here. And some doctors like the full borders, sometimes they're overextended, but some doctors they want the full borders, which I agree with. I like full borders. I think it helps with retention. If they're too overextended, then it could be, detrimental also. And once we get this back at the laboratory to preserve the borders, we're going to bead and box the model of the impression so we can get a nice accurate model. And I'm going to go through some laboratory aspects of it tonight too, just so we can get that communication aspect with us and the clinician. It helps us when we're communicating with these types of cases. So you're probably asking yourself, what about intraoral scanning for full arch cases? Well, it's possible, but still not perfect. Additional steps must be taken, and case selection is critical. So, but you can use an indelible pencil to help with stitching issues when scanning a particular arch where there are very few landmarks for reference. So there's still some issues when scanning a case for a edentulous arch. So in cases with tissue texture and landmarks, will be easier to scan as well. And we want to make sure we capture all those anatomical landmarks. So it's still there. We're happy, I see, when we get fully edentulous scans in the laboratory, some of the things I see is, the problems were the ones with those undercut ridges. So there was a study done by Professor LaRusso, and he did it in the edentulous scan strategy. And he used a 3-shape trios, and he does, for optimal scan experiences on edentulous patients. And it was a pretty good study, but because I'll show you what he did here. he took his scans and he had some directional values that he used when taking these impressions, like over here on his upper. He went from one side of the ridge to the other.
Hey, Dennis.
Yes.
Really quick. When you use your mouse to point at the screen, it blacks out for us.
Oh, it does. Okay.
Yeah.
Thank you. Thanks for letting me know.
Thank you.
Is that the first time that's doing that?
No, it's been happening, and I couldn't figure out what it was, and somebody from the audience diagnosed it for me. So
nice. Okay.
Thank you, audience.
Thank you so much. Yeah, because on my screen it highlights it. So I'm not gonna use it then. So I'll just show you the pictures. So thanks so much for the information, because it helps us. You know, we're still doing these things virtually. We're still learning as we go along here. So thanks so much. I appreciate it. But I wanted to show the direction that the Dr. LaRusso used for the successful, intraoral scanning of fully edentulous arches. Really worked out well, So it's something that, I think we have to take into consideration. But there were also studies done by the Journal of Prosthodontic Research. And this was an in vivo feasibility study, and it was computerized optical impression taking of 29 patients. And their conclusion was, within the limitations of the present study, the investigative scanners were not able to currently replace a fully conventional impression for the fabrication of a complete denture. So they didn't have success with it, but I'm seeing more and more success now with the different strategies with intraoral scanning. But look at the direction these scans were taken in when this research was done. Completely different from Dr. LaRusso. So that could have had an influence on the final outcome of the scan. So I like to bring that up when I'm talking about impressions here. So a little bit about pouring models. When we're pouring models in the laboratory, we like to use a type 3 stone for pull cases and maybe a type 4 stone for partial denture cases. Because for partial denture cases, we want something that's going to have more compressive strength. And type 3 stone is recommended for full cases because when we go to deflask the case, we sort of break up a little piece at a time when we're deflasking a model from a processed denture. And if we have a type 4 or type 5 stone, the stone's not going to break and the denture will break. So that's why we like to use a nice, accurate type 3 stone for full cases. And this is just some photos pouring models with type 3 stone, which is like your traditional buff stone or yellow stone. And type 4 stone, and we use vacuum mixer for all our mixes with stone. And this is just pouring the models with the type 4 stone. This is a partial denture model. And resistance to abrasion, low expansion, and high compressive strength. That's what we're looking for when we have these types of gypsums. So now we're up to the third visit with the bite registration and occlusal records. And it's important for us at the laboratory to get the information that we need to do a successful setup. So we want to have you mark the midline, the high lift line, the cuspid lines into the wax, so we have some guidelines when we're setting our denture teeth. And place those V cuts in the wax posterior regions and place bite registration if you're doing an upper and lower fully edentulous occlusal registration. So let's talk about bite rims. Let's make some bite rims. I like this photo here. This was taken in the dental school, so and with all these occlusal rims here. But just to give you an idea of what we want to give you at the dental office, I'm going to talk about functions and requirements, because our goal at the laboratory is to give you a nice contoured bite register occlusal rim, so it's less work for you in the operatory. You don't want to spend half an hour, 45 minutes cutting back wax and trying to get this thing to fit in the mouth so you can get the right occlusal plane. So we try to do that for you, and we have some tools to do that with, and we're going to watch that, and we're going to watch a little short video in a second. So what are the trial-based plane functions? With agent transfer and an accurate jaw relationship to the articulator. It simulates a finished denture base. So we want that patient to almost feel like that final denture, and it's utilized for occlusal rim and denture setups. And it should be a stable fit and rigid, accurately fitted to the model, have the proper thickness, clean and smooth, and we want this to really fit well, and we want that occlusal wax to be contoured correctly. And some doctors request processed bases, which we will process before and will become part of the final denture. And they use that in the final denture, but and taking the occlusal records also, and that's almost like that's like a finished base, So we get that sometimes. So, but the placement of the occlusal rim should be placed in the anticipated position of the denture teeth. So we have a suggested. I'm going to talk about the Alma Gauge in a minute. So we want to contour these wax rims to support the lips and the cheeks. And we want to make it nice and smooth and professional looking so the patient can see this and feel good about this, and you don't have to spend that much time contouring it. And we're trying to also establish lip support and have that proper occlusal plane level on these occlusal rims. To me, this is one of the most important steps in making a denture. And of course, you want that information from you on the upper occlusal rim. So the upper anterior height on average is about 22 millimeters. Occlusal width is anywhere from 8 to 10 millimeters, and the anterior width is about 3 to 5 millimeters. So we try to follow those rules and guidelines when we're making our occlusal rims. And on a wax rim, it's an average from the periphery to the incisal edge about 18 millimeters. And we try to cover the 2/3 of the retromolar pads when we're making these wax occlusal rims, because that's where the second molar is going to wind up when we're doing our denture setup. And I like to utilize a rim former also. This helps, and you can utilize this in the operatory too. It's a great tool, you know, and this helps you form that rim also. I have showed a little short video here from Dr. Frank Maselli from Articulator. He does a great job with this. So I'm just going to show a little video here. I hope you can see that okay. They look okay, Jessica?
The rim former is a tool that facilitates the fabrication of wax rims in a laboratory. It could also be used clinically to adjust the rim during the wax rim try-in appointment. The rim former has a 5 millimeter fence on either end and a wax spillway in the center. The tool has been designed so that it can be used either by a right or left-handed person. We're going to try in the wax rims and have the patient relax his lips. Typically, I like to have the patient count 1 to 10 or to have them converse in a casual conversation so that we can evaluate the incisal length of the wax rim.
2, 3, 4, 5, 6.
I think we could agree that the rim is too long for our patient, so I will mark where I think the rim should end, and we will adjust the wax to the desired length. The rim former is heated over a flame, and the 5 millimeter fence is positioned over the hammer notch area of the denture base. The rim former is slowly brought forward, melting the wax up to the designated mark. Note how the melted wax is automatically guided through the center spillway.
So there you have. That's a nice little tool to have in the operatory and in the laboratory. So we utilize that quite a bit. And again, just to reiterate, we just need that necessary information from the doctor on the occlusal rims, as you can see here. And another tool we use is the Alma Gauge. If you're not familiar with the Alma Gauge, what we do, we set the pin, as you see here, we set this in the papilla, incisal papilla, and we come out about 8 to 10 millimeters from the papilla. And this is on an average where those denture teeth are going to be set on an average with a full upper denture. So when we're contouring our wax rim, I like to actually utilize this Alma Gauge also. And I also utilize this when I'm doing my denture setup, as you can see here. So here we have a nice contoured wax rim. And then here's your perfectly contoured rims like I talked about before with all those measurements. So let's talk about taking the bite registration. Before we talk about that, I want to show this is another case I got in the laboratory. And the doctor wanted me to go to a finish, and I don't know what kind of wax he used. Looks like he used beeswax or alu wax, but it just wasn't a great bite. You know, there was an area, I guess, on the opposing that was edentulous, and I could not get these bites, the upper and lower together. And I said, there's no way we're going to do this. So I said, first of all, we needed a custom tray. We needed a better impression. This was an immediate denture. I wanted to get a better impression in the bite rim. So I called the doctor, and he told me the 5 words I hate hearing the most. And that is, Dennis, do the best you can. So when we hear those words, we know something's going to be wrong. So we try to get the right information from the onset. So so we wound up getting a new impression tray made and a better bite registration for this. And then it was a successful case. But I think if I would have gone ahead with this type of case, especially on an immediate denture, we wouldn't have had the right occlusion, and this is what wouldn't be accurate. So talk about taking the bite registration. We have this patient here on the left-hand side. You can see she's sitting back in the chair, and she's trying to struggle to get in the physiological rest position, and she just can't do it. So finally, we get her in that position here, but she's still struggling. She looks really uncomfortable. So this is why we really want that patient in an upright position when you're taking that bite registration. Then we have it pronounce the F sound of different words to make sure that the occlusal rim is contoured correctly. And that these are all photos, so I like to use them though because it just shows the information that we need. So this doctor is marking the midline, the lip line, and high lip line and the cuspid lines on this case here. So this is what we're looking at when we're in the laboratory trying to set denture teeth. You can contour it, you can add wax or take away wax, you can control the angle of the mouth with the wax. We try to do all this for you. So, but then again, we don't have the patient with us at the laboratory, so we try to do the best we can with contouring this. And also we need the right plane of occlusion. So we're going to use an occlusal plane, and we're going to use a ruler from the tip of the nose to the middle of the ear, which is a campus plane. And at times the doctor might even add, wax in the anterior region. So I know exactly where the incisal edge of the anterior tooth is going to wind up. But in this picture here, you can see that occlusal plane is sort of sloping down. And it's, something like this, we follow that occlusal plane, we're going to have a reverse smile on the denture, and it's going to be hard to set up these dentures correctly. So the doctor on the right-hand side is cutting this back and trying to get the right occlusal plane or campus plane, as you can see. So that from the tip of the nose to the middle of the ear, that is your campus plane. So as you can see here, I don't want to highlight this, I don't want to block it out, but you see on the upper right-hand side, you can see it's a better occlusal plane here. And then we're ready to take the bite registration and get it more accurate. And also, what's a great tool is the pupillometer, and I like to get the pupillometer reading when the final impression is being taken. Because what happens when I get this pupillometer reading, we know exactly where that patient's lip is going to wind up, and this way I can contour that occlusal rim correctly. I think we have a picture, a short video on this also, but you can see this patient, when in a relaxed position, is at 17 millimeters. So this gives us an indication of where the contour of that bite rim. So we're going to have Dr. Frank Lasilli give you a little video on this again on the pupillometer reading.
First thing I want to do is open up mic, please. And we're going to take the patient's denture out. And I'm going to take the pupillometer. It's a device that's going to help us give the lip line communication to the laboratory. And it has a little device in the back of here that's going to rest against the anterior papilla. And where this meets the gauge here, that would be at the 0 point. In other words, where it rests on the incisal papilla, that'll be our 0 point. And when we press this into the patient's mouth, whatever reading we get here will be interpreted as a number of millimeters between the patient's anterior papilla and the patient's lip as it's recorded. Now we're going to go to the patient, and I'm going to put this gently under Mike's lip here. And again, resting this against the patient's anterior papilla, we're going to let the lip just very gently and gracefully assume its resting position. And as I look at that from my position here, I'm going to measure that at about 14 millimeters. Now I'm going to ask Mike to, that's going to be the patient's low lip line. And I'm going to ask Mike to give it a nice casual smile. Now we're about 9 millimeters. We're going to consider that as our patient's high lip line. So we got a difference between low lip line, high lip line of 5 millimeters plus. And give me a little more of a smile, Mike. Maybe I'll put that measurement around 8 millimeters.
So there you have it. It's nice little video there. And, special thanks to Dr. Frank Lasilli from Ivoclar. He's probably one of the best removable clinicians I know. So really thanks for those videos there. But, once that bite registration is taken and you went through all that trouble of getting correct information, just make sure it's secure. Use a good bite registration material to maybe possibly put together the upper and lower edentulous occlusal rims. And we don't want to receive something like this at the laboratory because it's going to be a problem. We've gotten a lot of these over the years, so it's something that's going to move around. It's not going to be accurate, and we're going to wind up taking a new bite. So now sometimes the doctors just put V cuts in the wax rims, and so we can put some wax in between, and everything just stays together nicely. And then if I'm doing a fully edentulous case with full mouth reconstruction, especially on full implant cases, but also on full cases, I love a Facebook transfer. A lot of people get afraid when I say Facebook transfer, but it's like having the patient at the bench with us, in the laboratory. So I'm going to talk a little bit about Facebook transfer. One of my favorite ones is for the Artex Articulator. This is me when my beard was darker a few years back. I was kind of the guinea pig with this. It looked like something out of Silence of the Lambs here, but it was kind of funny when they were doing this trial on this Facebook transfer. But it's such a great Facebook because all you're doing you're keeping the face bow in the office. You're going to just take this off and send this to the laboratory on something called the transfer stand. Oh, sorry.
Your screen blocked out.
Sorry,
Thank you.
I have a habit of blocking. Yes. So you're going to take on a lower part on the left here. It's going to be that's going to be sent to the laboratory on the transfer stand. I'll show you what I'm talking about. I'm so used to highlighting these things. I'm sorry, but so the components are the 3D universal joint. You got the bite fork, disposable bite fork, a metal edentulous and face bow frame, and an Asian bar. Too many things to remember right now, but I'll show you. It's going to be easy. So what do we want to do here with a face bow function? We want to register the patient's maxillary hinge access relationship. And this for reference to correctly positioned cast on a precision articulator. Doesn't have to be an Artex, could be a whip mix, could be any articulator. We want to position those casts correctly though. And it ensures that a restoration or denture is made to the exact cranium access relationship of the patient. So we don't have the patient at the lab with us, but we have this information that you gave us, and it's going to really help us out a lot. So first thing we're going to do, say we have an upper and lower denture you're making, full upper and full lower denture. You're going to put V-cuts in those upper and lower dentures, upper and lower occlusal rims rather. And then you're going to take a nice occlusal registration, put that some bite registration material in between, take a nice impression, bite registration rather, take that out of the mouth. And then also the next thing you're going to do is spread the PVS material onto the bite fork. And we're going to position that bite fork on the occlusal surface of the bite block. And then we're going to position it on something called a 3D universal joint, a face bow. And that's what we see here. Once the face bow is done, we can take that universal joint off and we attach it to the transfer stand, as you can see right here. And what we're going to do is we're either going to take impression material or putty rather, or plaster, and we're going to attach that. You're going to attach that to the transfer stand, as you can see here. They utilize in this particular photo some putty, some lead putty. You can use plaster also. Once this is secured, you send that whole transfer stand to us at the laboratory. As you can see here, there's a transfer stand. Send it to us at the laboratory. Here's a picture of it here. And then what we're going to do is going to place it on the lower half of this. Happens to be an Artex articulator. We're going to place the upper model into the base plate of the bite rim. And then we're going to articulate. We're going to mount that upper model. And then we're going to just put that lower occlusal rim right into that V-cut registration that you took on the onset of the face bow. And here we have a beautiful face bow transfer, and we have all the information we need at the laboratory. So I love getting information like this. And just want to make sure when shipping these, just make sure it's packaged correctly, because I've seen many times where things weren't packaged correctly and things move and the readings go off. So excellent thing. You know, I love face bow transfers. I wish we got more of them. So, but you know, once you get the information, you know, we have to utilize a good articulating system also. So I like either a semi-adjustable articulator or a fully adjustable articulator. The straight hinge type of articulators, you know, that's not going to mimic true jaw function. We want something that's going to mimic true jaw function. You know, maybe have an intercondylar space of 110 millimeters as an average between the condyles, and either semi-adjustable or fully adjustable articulator will do that. So you can spend anywhere from a couple $100 to, you know, thousands of dollars on these articulators, but just get one that's going to be functional and work correctly time after time with consistency. So when you mount this on a semi-adjustable articulator, the occlusal plane is aligned and marked to the occlusal plane of the articulator, as you can see here. A nice occlusal plane here. And a lot of times I'll put a rubber band on the incisal pin and I'll go to the posterior region of the articulator, and there's notches on both on the incisal pin and on the posterior region of the articulator. And this is going to be your occlusal plane or your campus plane. And that's a beautiful articulation there. We have everything we need. It's going to be easy to set the denture teeth now. We even have all the information we need from the doctor, the midline, cuspid line, high lip line. And then this particular case here, this is the lower setup on here. You can see here, and there's the upper setup. Everything falls into line correctly, and the case is waxed and sent back to you for a try-in. We always try to visualize that the patient with us at the bench, like, you know, I mentioned that, but it's important, you know. So we visualize the patient, and we have the occlusal plane. We have, this is a functional bite impression that was taken with this bite rim. You can see it's 2/3 of the height of the retromolar pad, so we know where to set our denture teeth of our second molars. And this is illustration here. It just shows the campus plane from the tip of the nose to the middle of the ear. So all that's taken into consideration, you know, when we're making these full dentures. You know, it takes a little more time, but it's worth it in the long run. really is. And sometimes we'll get actually models from the operatory or from the dental office, and it's just sometimes we get the models that aren't trimmed correctly, and if we mount them like this, it's going to be a problem. It's going to be, it's really going to throw us off when we're setting our denture teeth. So we have to put a base on it and mount it correctly to the occlusal plane. All right, and we have to look at the Frankfurt plane, the campus plane, campus line, and the occlusal plane, well, the bottom well triangle.
Dennis, I just wanted to jump in really quick. Are we close to a break? Because we have a bunch of questions.
Oh, you do? Okay, yeah. Give me a little. Well, I was going to try to get into setups, but I can stop. You know what? How about we stop before this? I'm going to do a setup, and then we're going to get into the digital part. Let me get through this, and then we'll go into questions. Okay?
Sounds wonderful. Thank you.
Thank you. Beautiful. So, on an average, like I mentioned earlier, the length of the anteriors from the periphery is about 22 millimeters. And on the lower, it's about 18 to 20 millimeters. So sometimes it's a little longer, sometimes it's a little shorter, so I always try to keep that in mind. And then the fourth visit, we had by registration, we have everything articulated. We're going to do the tooth setup, the wax try-in. You're going to check occlusion, phonetics, and shade, and make sure the setups are pleasing for the patient. So, and this is when we're going to do, now we're going to start setups here. But before we do setups, I think Jessica said I have a lot of questions. We're going to go through a break here. All right.
Oh, perfect. I didn't know it was so close. I wouldn't have interrupted.
Yeah, actually, I had like 10 or 15 minutes, but let's do this now. Just so we can get some questions out of the way. Take a little break here, and I'll take a sip of water. How's that? Good.
Perfect. Okay, so I'm starting with those that are in Q&A. I'll go to next. I've got some that were sent to us to panelists. So the first one looks like, can I use a stock tray to take a final impression?
Yeah, if you get a stock tray that's really, it's pretty close to what the patient's arch, the size of the arch is, and you can border mold it correctly. I've gotten final impressions with stock trays. Sometimes I've gotten beautiful impressions with stock trays. But if you can capture the periphery and all those anatomical landmarks and get a good final impression with a stock tray, by all means. There are trays out there on the market that all you have to do is heat up the tray a little bit and then contour it to the patient's periphery, and they work out really well. Even some of the methods that are out there with the Mossad method and or other tray systems enable you to do this with a stock tray and avoid that custom tray. That's a great question.
Wonderful, thank you. And then if I duplicate an existing denture and take a final impression, can the lab manufacture a similar denture?
Yes, there's a couple of ways we could do that. So say if you took a wash impression in the existing denture, and what you do is, you could take that wash impression, send it to us at the laboratory with the opposing, or say if the patient had an upper and lower, take a wash impression in the upper and lower. What I like to do is actually mount these cases after we pour the models, mount these cases, and I'll take that upper denture off the model, and I'll actually do a setup against the lower, and vice versa. I'll set up the upper and lower while we have that exact vertical, and I can mimic that in the final denture. Those are the more quality-oriented duplicate dentures. I know the other technique is to take the existing denture, and we have a duplication flask where we have either putty or an alginate type of material, and we put that denture in there. We have an impression of the denture on the tissue side and the tooth side, and the alginate sets up or the putty sets up. We take it out. We actually pour tooth acrylic into the areas where the teeth were, and then let that set up. We trim it down, put it back in there, and then we pour acrylic in there. But I found out, I like doing it the way I just mentioned to you, to give you a good, solid duplicate denture that's going to last a long time. So there's a couple of ways you could do that. With that, yeah.
Thank you, Dennis.
Yep.
And then if the denture is very loose during the wax rim try-in, can I take a Reline impression at this visit?
Yes, that's a great point right there, because even with digital dentures, we do printed try-ins, and sometimes they're a little bit loose. And I always ask the doctor, if you see, even with the on a regular base plate, if you see it's really loose and the suction is not there and it's fitting okay on the model, but then something's telling you something's off there. So yeah, take a nice, at this point, I don't think you're going to have to border mold it too much, because you got a nice, but if you feel like you need to border mold it, go ahead. But take a nice wash impression inside that base plate, and we'll pour it up, and we'll either do a reset on here, or we can go right to a finish. But that's one of the most accurate ways to, get a good fitting denture. It's a good point.
Great, thank you. And then would a digital scan as well as a CBCT submission help in making a more accurate digital impression?
That's a good question. Yeah. So what we're doing, there's some new technology out there now with a couple of the scanning companies, which merge those types of files, those two files. Plus, there's actually we merge three things: the actual wash impression and those two files to really get an accurate impression. But most of the time, we're not, something like that. We're not going to be utilizing an actual impression. But there's technologies out there now I've been reading about that you're able to merge those files. I'm not utilizing that right now. We're just using the regular iOS scan, but we are using that for implant cases. So the Cbct scan and the iOS scan, or the impression. So we still have a little ways to go with the fully edentulous scans, but we're almost there. I tell you, I've been seeing such great scans lately. The only reason, I just came from a dental meeting also. We talked about this, and we talked about those really bony ridges with undercuts where we just can't get that final scan correctly. So and with this one company that's out there that's doing this workflow for digital dentures, they're actually scanning the intraoral scan and merging the file of the wash impression. This way we get a good, accurate impression. But it's whatever works, whatever's more accurate, that's what we utilize. So.
Thank you, Dennis. Someone asked for comments on a couple, and one of them was, you did cover the pupillometer, but they're also asking the allometer and the Gothic arch tracing.
Oh, that's great. Yeah, the Alameda, I don't have that with you. I actually had an Alameda in my hand the other day. I was going to bring it tonight to show you. And the Alameda is great because you can take the measurement of the nose, and it gives you pretty much the size of the denture tooth you're going to be utilizing. And the Gothic arch tracing device, I didn't add that in today. I didn't think I was going to have enough time, but I do have that. If we have time at the end, I have it's an advanced workflow for dentures. And I'm not too sure we're going to have time to talk about that today, but I think the Gothic arch tracer is one of the most accurate ways to take it by registration. So that's a great point there. And with digital technology, we're able to print out a base plate that accommodates a Gothic arch tracer, and then get that information and then scan it into the software and get a nice, accurate virtual articulation, which is great.
That's wonderful. And instead of using averages, why not use the values uniquely determined by the patient's landmarks on the maxillary arch and utilized Staub cranial analysis to help fabricating the wax bite?
Yep, that's a good point. You can use that. And this, I'm talking about on an average what is being done every day. So what you're talking about is a great technique. Stop cranial measurements, and that's worked fantastic over the years. So there's so many different things to talk about on tonight. I'm talking about what we do mostly, what I've done mostly over the years to get a good, accurate, and successful denture with these different techniques. I would love to put together an advanced course, which I have a lot of this information that you mentioned here between the Gothic arch tracer and the stop cranial information, and that could be a whole other course here. But that's more of an advanced course, and so this is a lot of the things I'm talking about tonight, or the measurements that made it possible for successful dentures for me over the years. And it's funny, I'm laughing now because I did an evaluation of how many dentures I did. One night I was sitting in my hotel room. I don't know why I thought about this. So I just started to think about how many dentures I did over the years. And this is the time when I started my laboratory to the time I sold it. And I did close to over 70,000 dentures, so that's a lot of dentures. So, and no remakes. Only kid. There were remakes. But yeah, it's a good question though, Doctor. Yeah, it's a good question, and it should be addressed, and it's not addressed enough. These different types of occlusal methods that you're talking about.
So sounds like we're going to have excellence in denture technology session 2, the advanced course.
The advanced class. Yes, that's good. That's going to be a good one. Yeah. So,
we got another one for your comment on using the HIP plane. I might not pronounce this right, sir. I'm sorry. Hamular notch incisal papilla to aid in determining the occlusal plane.
Okay, I'm not understanding that.
HIP plane, hamular, H-A-M-U-L-A-R
Yeah, the hamular notch
notch.
is a hamular notch, right? And then you talked about the papilla, incisive papilla.
Yeah,
Maybe that was
hamular
the
notch incisive
maybe that was
papilla.
with the Alma Gauge you were talking about. If you can
Yes, same person.
Yeah, the Alma Gauge. Yeah, but well, the Alma Gauge, I'm not too sure. I'm a little confused with the question there, but the Alma Gauge we use all the time as far as gives us an idea on an average where to set those anterior teeth, and it works great. And we utilize that with the doing setups and making the occlusal rim.
Great, thank you. And what are some tips to get a good Reline impression?
Good question. Well, first thing is, if you see how that denture is fitting, it's just really loose, or maybe it's hitting hard on one side. I always say just to ream it out a little bit with a nice carbide burr, maybe an 88.8 carbide burr. Go in there and ream it out a little bit, and then good Reline impression. I still say I would just add some of the heavy body on the borders, and then take if it's not that much resorption, I would say light body material. But if there's a lot of resorption, use a medium body PVS material, and then send it to us. And I do a lab reline. I'm not a big fan of doing a reline on a reline jig with self-cure or cold cure acrylic. I like to have a nice high impact acrylic with flexural strength, and the fit is going to be better. There's going to be less shrinkage, and that's a good way to do it. Unless you're doing something in the office, if you want to do, in the operatory, there are a lot of great chairside reline materials out there in the market also. There's a number of different companies that have, Keystone has one, GC, good chairside reline materials, but they're more of a soft liner type of material, but they come in different viscosities. There's the medium and hard material. So if you're into chairside materials, that's a good material to go with, those chairside auto mix materials. But there's nothing like a lab reline. Let me tell you, for a fit, a good impression from you, border molding and good wash impression, and then we'll do the processing at the laboratory.
Thank you, Dennis.
Yep.
And audience, just to share, there's 3 questions on the board. I'm going to do a cutoff so Dennis can then get, after we ask them, so we can get into the second half of the content. But to go to this next question, how well does the Octopus suction cup design work on lower denture bases for retention? And I want to see this.
That's good. I don't have it. There's a picture of that. I've done a few of these over the years, the suction cup dentures, and they worked. They worked. Most of the time we did them on uppers. I did a few of the lowers, but I haven't seen them in years. I haven't seen one of those types of dentures in years. But those suction cup dentures, I remember getting. When I was in the laboratory, when I had my laboratory, getting a kit by from a doctor asking me to do a suction cup denture, and I said, "What the heck, suction cup denture? I never did this before." And it worked well. But if you notice, after a certain amount of time, that edentulous ridge almost is like tattooed with little spots on it from the suction cups. But it's pretty interesting. Yeah, it's a suction cup dent. It worked when we did them. I didn't do a tremendous amount of them. But on a lower, I really can't give a definitive answer. I know the ones that we did worked out well. I only did a few lowers. Most of the suction cup dentures I had were on the upper dentures. So,
next question is not achieving good suction and retention with a Reline impression an indication that this is not a good impression?
Good. That's a good question there. Yeah, if that's coming out pretty easily in the impression, then it's But then again, you might not have that many undercuts to hold that impression in. I've seen it both ways over the years. As far as because when I had my laboratory, I had I think we had 6 or 7 dentists in the same building, so I was constantly being called down to the operatory to work with the clinician, which is great. Got some great experience. And I've seen what you're talking about. So and I was a little bit leery when that happened. And sometimes it worked out, sometimes it didn't. So I would say if it's really loose and you're having a problem with it and without any suction, and it depends on the material you're using also. Make sure you have a good, it's a good impression with that the PVS material or even the rubber base material. It's still see the rubber base being used. But if you really have a question, you don't feel comfortable, then retake it.
Thank you, Dennis.
You're welcome.
And the last one, so you can get back to content, is because a scan makes no contact with the tissue, will the fit of the denture differ from an analog impression?
Actually, that's a good question because we have the most problems we have is that really flabby soft tissue area. And that's why I was talking about before, the indelible pencil to put dots on those areas for stitching. We have stitching issues, but a good scan of the edentulous ridge, if you get a good scan of it, it's beautiful. I mean, we have the fit is amazing, when we get a good scan, but most of the time, and I'm being honest with you, most of the time we're scanning the models or the impression for digital dentures at this point, even we're having a doctor scan, with our new three visit digital denture, we're having the doctor scan the existing denture with a wash impression and the by registration and sending that STL file to us at the laboratory. But you'll see later on when we hopefully have time, I can show you some of the details on the screen with a scanned denture. I mean, you can see everything. It's so accurate. So, thank you for the questions. Thank you.
Thank you. Do you need a minute to rest your voice?
Yeah, let me just,
I'm
going to take a sip of my water. I got plenty of water here, so I'm good. Okay,
I'm
good.
Thank you, audience. Yep.
Yeah, thank you, audience. Thanks so much.
Yeah, your engagement, and then go ahead and put any additional questions in the Q&A or in the chat box, and we'll let Dennis get back to the content, go through the next session, and we'll be stopping again at about 8:15 so we can address all your learning curiosities then.
Great, nice, good. And some great questions. I haven't heard some of those terms in a long time. The suction cup dentures and everything else. A couple other things you were talking about there, but it's great, but some great techniques there. And, maybe we can address this next time when we do a continuation of this type of this type of seminar.
Part 2 coming soon.
Yep, that's it. Yeah, but it's time to do a few setups here. Let's just look at some setups here. And before we talk about setups here, what about denture teeth? I can remember every time I do my in-person lectures, I'll go around the room and ask everybody, does anybody know the differences between the denture teeth out on the market? I get like 2 or 3 hands in the room, 4 hands maybe, but there's some major differences in denture teeth out there. You really want to use the correct denture teeth. And there's some great brands out, between Vita, Colzer, Ivoclar, and some great denture teeth out there. And you want a tooth that's going to wear like natural dentition, especially on implant cases. So we want this the same size as natural teeth, high wear resistance. And I like lingual anatomy on the anterior teeth for better phonetics, especially for new denture patients. They have trouble speaking. It takes a while for them to get used to that denture. Sometimes they lisp. And if you're doing a combination case, of course, you want denture teeth with 3D shades, because a lot of the crown and bridge cases on the anterior regions now are taken with 3D master shades. So there's a lot of things to look at. And here's a denture here with rugae and denture teeth with lingual anatomy. And this is beautiful. So this is going to really feel comfortable for the patient. And sometimes I'll even mimic the patient's natural rugae. I'll take a wax impression of the rugae from the impression. I had a stone model, and I'll incorporate that into the denture. And it'll feel just like that natural rugae on the roof of the mouth of the patient. So, really want something that's going to have a functional cuspal inclination. I'm not a big fan of 0 degree or 5 degree teeth. I want something that's anywhere from 15 to 33 degrees. It depends on what the patient can tolerate, but we want the patient to tear and chew their food and not slide like a cow, and I like the wider occlusal plane on these posterior denture teeth, especially for partial dentures. I've seen so many denture teeth out there that just have such a narrow occlusal plane. It doesn't look natural. It's not conducive to great eating and tearing of the food. So we want to make sure you have that type of wider occlusal range on there. So, and you want different emergence profiles to choose from, and it depends on the patient. But how do we select those anterior teeth? Well, what I've done over the years, I take the shape of the arch. I'll take a full upper model, right? I'll hold it up in front of me. And if you look at a full upper model, it pretty much looks like the shape of a central. It could be a tapering arch, tapering ovoid, square arch. And I pretty much go by the size of that arch, and that's how I pick my denture teeth. Or else I can look at an existing case and look at the study model. Or sometimes what I'll do is I'll take the occlusal rim, and I'll measure from cuspid to cuspid on the occlusal rim in millimeters, and I'll go to the manufacturer's tooth chart, and it'll give me an idea what size tooth to use. So, and then, I try to utilize this tooth chart. So there's a lot of things you can look at when you're picking out denture teeth, and tooth form equal facial form. This is another old slide here, but as you can see here, tooth form, anterior tooth form, most of the time equals facial form. So square face, square tooth, square tapering tooth, and so on. And then you look at the sagittal and frontal considerations. You know, its tips and the canines are usually equal to the width of the nose, and the width of the centrals are usually equal to the width of the philtrum. So we have nice anatomical landmarks to go by with that also. So, and we're going to keep in mind facial features, you know, and we talked about before getting a photo of the patient with at the bench, you know, having it at the bench with us so we could see what that occlusion is like. And sometimes I get even little short videos of the patient going to different excursions, so I can judge a little bit better setting these denture teeth. You got your pupil line, which is in line with the occlusal plane, your midline, your cuspid lines, and your smile line. So all this we take into consideration when we're setting our denture teeth. So I'm just going to give you a little bit of the laboratory aspect of it. I know we do a lot of work with prosthodontists, and prosthodontists love setting their own denture teeth, which is great. We love just brainstorming with prosthodontists about setting teeth. And so I'm going to talk about my method I've been successful with over the last 40 years with Denture Setups. And we want something that's going to be harmonious and aesthetic. So the anteriors are positioned individually and parallel to the pupil line. And the lower incisal edges are parallel to the upper incisal edges on these types of setups. And what I'll do first, I usually set up my upper anterior teeth. Then I'll set up my lower anterior. Then I'll start with the upper bicuspids and lower bicuspid, go back and forth, and I'll use an occlusal plate for that. And when I'm teaching my setups, I always tell the beginners to mark the crest of the ridge. You know, circle the retromolar pad because we're going to and just put a line through maybe half the height or 2/3 of the height, just to give them an idea when they're setting a denture teeth where to go. And you really don't want to deviate from the crest of the ridge on the lower, because it's not going to be a stable denture. So I try to stay right on that ridge. And there's your papilla here. This is what I measured before from the papilla, about 8 millimeters out to the to set those anterior denture teeth. So this is a case where I didn't get any information at all. So I got, we had 40 millimeters of intraocclusal space. So I'm going to show you the basic method here. So I'm setting this denture here at my base plate. And, I see a lot of people setting denture teeth, they set them against a ridge. So if you had maximum ridge resorption, like on a lower photo here, the patient's going to be sunken in. And the minimum ridge resorption is, that's when I'm probably going to come out about 7 or 8 millimeters from the papilla. But I'd say half the time I'm getting some guidelines from the clinician about where to put those anterior teeth, either building out the wax or just adding a little bit wax like we showed earlier on the incisal, so I know where to set those teeth. So that helps us too when we're setting our teeth. So what I'm doing here, I'm placing my upper central. I make sure the incisal edge points towards the buccal fold. And you can see on the right-hand side, I'm about 8 millimeters out from the papilla. And then I place my centrals at the correct inclination and my laterals. And at this point, I'll take an occlusal plate. And I want my centrals and my cuspids touching that occlusal plate. And I just want to verify that incisal edge. And I like these clear occlusal plates because it acts like a mirror. You really can see the contact on the occlusal plate. So I want to check for a symmetrical arrangement. At this point, we can alter it. We can make it like a bolder arrangement or softer arrangement according to what the patient had or what the request was. And there you can see the central and canine on the occlusal plate. And the lateral is about 1 millimeter off. So then we're going to set our lowers, allowing for about 1 millimeter of vertical horizontal overlap, keeping in mind inclination. So I like at least 1 millimeter of horizontal overlap, vertical and horizontal overlap when I'm setting my denture teeth. And in the advanced version of this course, we're going to talk about physiological centric occlusion, where we have those 30 points of contact on each arch and even hard contact on the anterior region. So I don't have time to talk about that today, but this seems to be very comfortable for patients who we allow that 1 millimeter of vertical horizontal overlap. So we're setting our lower anteriors to go follow the uppers on this. And I'm going to jump from there now. I'm going to go back to that, but I want to jump there from that. Remember that functional impression in the beginning of the webinar, where the doctor took a functional impression and by registration in one visit? Well, this is the case here. So, we have to make a new base plate on here, but I want to preserve the information that was given to us. And so I made a little putty index here, and I know exactly where to set those denture teeth. And so I'm going to make a new base plate, and I'm going to set those denture teeth right according to that putty index. And so I know exactly where to set this. So I have a record now, and I have a brand new base plate that fits really well. I'm going to set my anterior teeth like I did before, and just follow the guidelines of the upper when I'm setting my lowers. So let's go back to the previous setup here. So we have to figure out what kind of posterior teeth and what kind of occlusal scheme we're going to look at. So, we want something semi-anatomical or anatomical. You want a 0 degree lingualized occlusion. You have to decide what kind of occlusal scheme we're looking at here. So And this, take into consideration, we all would like to get class 1 normal bites on all these cases, but probably maybe that's 1 out of 10 cases where we get this. So we get a class 2 bite or a class 3. And with a class 3, this is when I'll use probably a less cuspal inclination. At least a 5-degree tooth on this on class 3 bite is what I've been successful with. And there's your different kind of contacts here, and lingualized occlusion I'll talk about more in my implant courses. But even with full cases, we get asked for lingualized occlusion, which is a lingual cusp falling right of the upper, falling right into the central fossa of the lower, and it creates a more comfortable feeling for a lot of patients with lingualized occlusion. So typically, the smaller the ridge, the less degree of tooth, and the greater degree of tooth, the greater degree of cuspal inclination. Now, I'm not saying that's for all the cases, but this is the guidelines that we're following pretty much all these years. So again, we're ready to set our denture teeth here. This is just a model with the drawings on here. And so the axial inclination of the posteriors are centered to the cranium when we're setting these denture teeth. In other words, that's our Kerber-Wilson, as you can see here. We try to keep along those guidelines. And let's just take some notes here. Look at the notes on setting posterior teeth. We want to make sure the central fossa of the teeth are on a lower ridge. We want to check our vertical inclination of the posterior teeth, check our curve of Spee, and a curve of Wilson that I just showed you as a review. There's your Wilson's curve, and there's your curve of Spee from the anterior to the posterior. A nice curve there, natural curve. So this is what we try to achieve when we're setting our posterior teeth. So this is going back to that case here, and then we're going to set the my first upper bicuspid. I'm going to have that full contact on the occlusal plate. I think this is a 23-degree tooth I'm using here, and then I'll set my lower first bicuspid to interdigitate correctly. Then I'll set my second bicuspid, as you see on the lower part of the screen, and I'm going to have contact with on the cusps here. And then I'll start setting my first molar. And if you look at the upper here on the first molar, I usually have contact on the mesial, and I'll take that distal cusp off that occlusal plate. And the second molar, as you can see on the lower photo, I have no contact at all. Now, this is my method. I'm used to this. You can use a template to allow it with the same results as this, and you can get that curve of Spee. That's what I'm trying to achieve here. So at this point, I want to make sure everything's in line. The height and contour of the teeth are working well. I use a PTC template here to do that, and I'll make sure the occlusion is correct with working and balancing, and make sure no interference, and we're ready to wax up our denture. And this is the waxed up denture here. You can see the nice anatomical carvings in here, and it's a beautiful try-in. And we're going to have to send this to the doctor, and hopefully everything looks good. So we have a nice harmonious transition to the posteriors and nice individual anterior setup on this. So it's a nice setup here. So I'm going to jump to just a quick other method here. It's called the template technique. So a few years back, I was managing a large lab down in North Carolina, and we had a 40-person denture department. And we were trying to get a good, accurate setup, but also increase production at the same time. So I got a call to try this template technique, and I was a little skeptical and apprehensive, but it really worked out well. So pretty much the same guidelines that I was doing here. So we're going to say, for instance, this is a sample case here. So I exposed the papilla here, and I did the same thing. I had 40 millimeters intraocclusal space. I set my upper 6 anteriors, checked the arrangement on the occlusal plate, contact on the centrals and cuspids, set my lower anteriors, and at this point, I took my upper model off the articulator, as a magnetic mount, and I put this template on. So all I did here was I was going to set my lower teeth right against that template, and if it cusp degrees from 0 to 35 degrees. So, and what I did here, I just set all the posterior teeth against this template that was attached to the articulator, and it was in no time. I think it took me like less than 5 minutes to set these teeth. And then there's a lingual view. So you have a nice contact. We have a curve of Spee here, curve of Wilson. Check everything is verified. There's your lower tooth setup. And all I did now is just set my upper teeth to the lowers. And I did this setup in like half the time. It was great. So we achieved our goal there of getting more production and with a nice accurate setup here. And this is the final wax up for the try-in here. So this is a little more dramatic here. I wish I could highlight this, but with the highlighter, but I can't. But you can see the veins and striations and carvings in here for a nice wax setup here. So there's a close-up. And when I wax a try-in, I use different aesthetic waxes. I get calls all the time from doctors saying, hey, can you mimic the patient's natural gingiva? I said, yeah, we can do that in the finish, or I can even do it in the wax up. So I have so many different colored waxes. So sometimes I'll get a photo of the patient's gingiva. We'll have it in a try-in. You know, it costs more. Believe me, we charge a little bit more for this, but we have it in a try-in. I'll take a digital photo of it. This way, when the case is finished, I can use a denture-based stain to mimic what I did in a try-in. So so I shape everything correctly, and the precise shaping of the wax is important when we're characterizing. And which would you prefer, the one on the left or the one on the right? So that's why I try to have the patient, you know, send something really nice to the operatory. You know, we do diagnostic wax ups for crown and bridge. Why can't we do a nice characterized wax up for dentures so the patient can see what that final denture is going to look like? There we go. All right. So we're going to get into a little bit with denture bases for a few minutes, and we're going to jump over to the digital side of things. So denture bases, there's a lot of acrylics out there. We come a long way with denture acrylics over the years. We want something with a natural look, a low shrinkage factor, a variety of gingival shades, something that's going to bond well to denture teeth. Of course, denture teeth are a lot harder now. And years ago, they were softer, especially on a ridge lap, and it bonded a lot quicker to acrylic or methyl methacrylate. And so we need something that's going to bond well to denture teeth. Impact resistance. We need that flexural strength with impact resistance. Without that flexural strength, you're going to have a brittle acrylic, and something with good finishing and polishing properties, and cut and fit stability, pillar and fit stability. So there's many ways of processing dentures out there, including, the digital aspect of it. But studies have been done. The most accurate way to process a denture is with injection. And one of my favorites is the Avid base here. And it injects that acrylic against the model at all times, and while it's curing. But what I found also with the heat cured acrylic I'm going to show you is it's just as accurate. I mean, I have with conventional investing in packing, it might not be as accurate as I shouldn't say it's just as accurate. Might not be as accurate as the injection, but it is really accurate. And the conventional investing and packing method is still the most widely used method for packing dentures. So these are some dentures I made just to show the various shades out there. This happens to be Diamond D acrylic. There's other acrylics out there, like I mentioned, Ivoclar, Reyes. There's a lot to choose from. But we want something that's going to look natural and with that high impact resistance. And we talked about denture-based staining earlier, and so if we really want to characterize these dentures, I'm going to go through this in a minute here. I'm not going to go through these right here. I'll show you the actual photos. So after the denture is finished, what I'll do is I'll prepare the surface with a diamond burr or a carbide burr, and I'll start applying these stains. And what I'll do is apply these stains a little bit at a time. I'll light cure them. And this happens to be light cure material. And you can see how nice this is being characterized. I light cure for about 15 seconds for each in between each. And then once I'm finished, I'll light cure it for I think it's about 3 minutes, and then I'll add some glaze to it. And there's your finished results of a nice case. And this stays on it. This does not wear off. So, there's a couple of different denture-based stains out on the market, and this particular one happened to work really well for me. So that's what you want to really get dramatic. How about that one? I didn't do this case, but this is a case that was done by a technician in Germany, and did a beautiful job here. But these are with the PhysioDens denture teeth on here. But so after that, you have the finished denture, the fit visit. You're going to have final insertion, check for fit, form, and function. You're going to check for pressure spots, and then if you have to, you can equilibrate the occlusion. Hopefully, you don't have to spend time doing that. At the laboratory, what we do, we put it back on the articulator after the case is processed to check for the occlusion, the original occlusion that was given to us. Sometimes there's a little adjustment here and there. So, and there's that denture in the mouth there. Nice. You see the nice contoured lower denture. I try to put some irregularity in there on the anterior. But we had questions already, so I'm going to jump from here. We're going to get right into the other presentation here. So this was meant to be earlier, but so we're going to get into, that was the analog or the traditional way of doing things. Let's talk about digital. And I call it the great challenge because there's a lot of people in the mindset that really want to look at digital dentures. There's others that are really embracing it. And it's an evolving technology, and it's changing as we speak. So especially with printed denture technology. We've come a long way with printed denture technology. We want to make sure we're moving in the right direction, though. And we talk about digital and analog. You're still going to have to apply those analog or traditional sciences over to the digital side. Really important to do that. So the digital transformation, I call it. It's preparedness, production, and profitability in the digital world. Of course, we want profitability, but the ultimate goal is patient acceptance and satisfaction. So you want to engage your patients. Now you can deliver personalized, rich, connected successes with consistent, positive patient experiences, digital dentures. And, you know, us at the laboratory, we empower our technicians with the fast-moving clinical accounts, efficiently collaborating with you and our technicians to anticipate and meet customer demands in real time with digital technology. And optimizing your operations, increase the flow of information across your entire network, like I mentioned before, and your operation rather, and better manage your resources and your practice processes, and synchronize these across all the boundaries. And expand the reach of your capabilities using digital channels, you know, so, and that just doesn't mean dentures, you know, it could be all throughout all of the restorations that you're doing. So let's talk about digital and analog. So we need to utilize the same fundamental prosthodontic processes to make a digital denture as we always have. And the clinician still needs to communicate, provide the technician with the necessary information for a functional case. Digital denture technology is still evolving, like I mentioned earlier, and improving at a rapid pace. And the basic knowledge of prosthodontic principles, including providing accurate impressions, is even more important in the digital world because many details can be seen on a large screen, which could not otherwise be detected. And we'll show that in a minute. And dentists still need to understand the importance of capturing accurate maxillomandibular records, vertical dimension, and centric relation. And the technician needs to continue to analyze visual relationships and then select the appropriate anterior and posterior teeth for the desired occlusal scheme. But we actually come past this now because a lot of times the software in 3Shape and Cad will actually pick out those denture teeth for you due to the measurements of the arch. So looking at the workflow comparison, we talked about a traditional workflow earlier with 5 visits. Well, with the printed denture, we're going to talk about printed digital technology first. And that first visit, you can, if the dentures are in good shape, the patient has existing dentures, you can take that impression or take a wash impression of the dentures and scan the impression and the bite. You know, so that'll save a couple of visits right there. So we're going to try to get this printed digital denture down to 3 visits. So as you can see here, this is actually scanning. Bite registration. Getting a nice quick scan of the upper impression and the lower. It's kind of accelerated here. So, and this is sent to us at the lab, and then we can put this on a virtual articulator and go from there. So that second visit is going to, instead of getting your traditional try-in, which I spent all that time putting that beautiful wax on, you're going to get a printed try-in this time. You know, so and the printed try-in is more of a monolithic look to it. So, and I'll show you what I mean. So it's something that's going to be printed. It comes in various shades, but really, you know, what I try to do, I try to make it look more natural. So I'll talk about that in a minute, how I can make this look a little more natural in the mouth, but it really works out well. I mean, the printed try-ins are great. If there's a problem, you can always grind down the teeth, take a new bite registration. You can even take a new wash impression if you're not happy. And we can scan that and merge it into the existing file. And we can either do another printed try-in or go to a finish. So this is the printed try-in in the mouth, as you can see here. So let's talk about fabricating that printed denture. So we're going to talk about the Lucitone printed denture here. So first we have case digitation, case design, a printed try-in, and the printed final denture. So the first thing we do, we enter, this happens to be 3Shape. We enter all the information on the patient into the work order form on the computer, and then we'll start for the case digitation. And what I mean by that, we're going to either scan a model or final impression. And this is what I was talking about. You know, just scanning a model on this. Look at the accuracy. You know, I wish I could make this a little bigger here, but you can see the accuracy of, you know, the having the notches, the periphery, and things like this. And this is just a scan of the model. Or you can scan the final impression too. And that works well also. But I like scanning the model. But impressions work fantastic too. This is what I'm used to. You know, so, and the next thing I'm going to do is, you know, once we get the bite registration, you know, on this type of case, say if we didn't have the traditional or the shortcut of taking an impression in the denture, and we had to start with a preliminary impression in the custom tray or whatever, and we had to scan the bite registration. I spray it to scan spray on a bite registration, and I scan the bite registration here, as you can see. And all that information is going to be incorporated into the software and set up on a virtual articulator. So everything is done really quickly, saves a lot of time. So the virtual articulator allows for centric and lateral excursions, therefore saving the dentist valuable chair time on adjustments. And I'm going to show that here in a second here. So you can see the fully adjustable articulator here, and you can see all the contact points here. You can adjust these, and we'll talk a little bit about some adjusting the teeth later on. Digital denture setups, the impressions are digitally articulated to the bite registration using special software, and denture teeth are placed following the arch shape and the bite registration. And the vertical height can be adjusted in the software to open and close the bite if necessary. And these are full arch setups. When you have a full upper, full lower denture, these are full arch setups that come into play, as you can see right here. And the software proposal is reasonable and can be modified using software tools. There's a lot of tools out there, so it takes a little getting used to using the software. It's not like you can just jump on a computer and start designing a case. It takes a little while to do this, and really have to know what the science of occlusion before you do this. That helps out. So using the software tools, every aspect of the denture digital wax up could be adjusted or smoothed. So I can print out, even with the denture try-in, a printed try-in, I can have all this anatomy in that denture, even festooning, even stippling. So when the final denture is printed, there's really no finishing. Everything's done on the computer here and beforehand. And there's your completed denture design. Once we get that information, completed denture design, or we tried it in, and the doctor says go to completion, then we're ready to print the denture. So this is we talked about the printed try-ins earlier. They come in different shades. And, if the midline's off, you can mark it with a Sharpie, and we can scan that, and it'll automatically be adjusted in the software. And you can take a wash impression, or you can take a new bite registration. So how can we make a printed try-in look more natural? Well, I'll take my traditional method that I used before with a traditional wax try-in. I'll have different color waxes, and I'll have really molten wax, and I'll just spread it across the printed try-in, and I'll already have my carvings in there from the anatomy that I put in there on the computer. And now we have a nicer looking printed try-in. But just don't go sticking a hot spatula in that printed try-in, because you're not going to be able to move teeth around like you would in traditional wax try-in. So these are aesthetic color wax here. I have a lot of different color waxes I utilize, with these types of cases. So let's talk about printing the denture. Ready to print the denture now. Again, this happens to be the Lucitone printed denture. So we scan and design. We send in information to the printer. We're going to do something called wash and recycle. I'll get into this a little bit more. We're going to fuse the denture teeth in there, and then we're going to finish it. So this is the printed denture base, and we come a long way with printed denture bases. 2 years ago, if I saw a printed denture, I would just shake my head no. I mean, it was just, I didn't like the aesthetics. It attracted bacteria. It wasn't that strong. And now we have a denture-based material that's strong, and the colors and shades are great. So you have a lot of choices to choose from. So we're setting up our printer. We pour this liquid in here, and I think we could do about 8 to 10 at a time here, different cases here. So we print these dentures. We're not going to cure these all the way, because at this point, we're going to remove some of those supports, but we're going to leave those supports, if you can see on the right-hand side and the lingual and the lower, we need to leave those supports in there because the denture is not fully cured. And at this point, we're going to put in denture teeth. First we're going to clean it. We're going to put in these special denture teeth. This is the Dentsply IPN teeth made for digital dentures. So we're washing this off now. We want to get it nice and clean. We use a denatured alcohol material, liquid rather, and we dry it off. And now we're ready to put the denture together here. So the 3Shape Design software has a characterization point set to indicate the position of the retromolar pads, canine points, ridge points, and that's coupled with the use of Pound's triangle. And this allows the software to pick the mold for us, so there's no guesswork on picking the correct mold. So we don't have to go crazy trying to pick a mold out. I still pick out certain molds on certain arches, but this helps us pick out those anterior teeth and posterior teeth. And on this particular printed denture, there are a couple of different systems out there, but this particular one is the IPN 3D denture tooth. And what they did, they eliminated some of the ridge lap on there. So it's a lot thinner tooth there, but it fits perfectly into those sockets on that printed denture base. And there's all your mold choices. They're increasing the mold choices as we speak. They're always coming out with new molds here. So the first thing we're doing here, we want to condition those denture teeth to really bond well to the denture base. And we use something called the Fuse 1 material. And we put that into the denture base. We put it in there. We light cure it for a few seconds just to hold it in place. I usually do 3 or 4 teeth at a time. And then after I do that, I'm going to put in, I'm going to use something called the Fuse 2 and Fuse 3 material. And the Fuse 3 material is going to seal all those gaps between the teeth, interproximally between the teeth. And then we're going to do a final cure. It's going to call post-curing. That's for about 22 minutes. And once that comes out of the post-curing, all we have to do is cut off those supports and polish. And that's it. There's your printed denture. So it's pretty cool. I mean, I love the technology, and the fit is great. Really is. There's a finished denture right there. And you can use denture-based stain on here. You can stain the denture to make it look a little more natural, but the colors are pretty good. So again, analog versus the printed denture. You know, we have reduced chair time on the printed denture, little to no adjustments, digital pre-occlusion, better patient acceptance with fit and aesthetics, peace of mind with the final denture outcome, and that digital file is always available. So if the dog eats the denture or the patient loses the denture or breaks it, we can print another one in no time. So it's pretty cool. And something I love about this Lucitone printed denture, they call it the BAM factor. And it's a body activated material. So when the denture is placed in the mouth, the strength of the material increases from 1,500 joules per square meter and it doubles to 3,100 joules per square meter. And what does that mean? That means that the impact resistance and strength increases. So that's pretty amazing. They drop these dentures off of roofs and they run them over with cars and the test. You know, I've seen some videos online on YouTube. It's amazing how strong it is. So there's your Lucitone printed denture. So, and just to elaborate a little bit more, we're utilizing printed technology now for hybrid denture cases. You know, with all on 4, all on 6 type of cases, and we're utilizing the surgical guide to give us the exact access holes where the temporary cylinders can be cured into the denture. And this is what the printed denture looks like, you know, for a temporary hybrid transitional. And there's all the access holes where this temporary cylinders are going to go into. So we're using this, and I talk about this more on my implant denture seminar. So there's a lot of other things we could talk about. So stay tuned for that too. But so that's pretty much your printed dentures. There's a couple of other systems out there on the printed technology, and you know that seems to be one of the ones that I like the most as far as the shading and the strength and the aesthetics. So we talk about mill dentures. There's a lot of different systems out there too. You have Ivoclar, you have the Sterngold Baltic denture. There's Vita, and a lot of different types of mill dentures out there. But I'm going to talk about the Ivoclar one today, and it's a simplified mill denture workflow. And this is what I'm going to show here. It's similar to the other one I showed, you know. But this one, at the first appointment, we're going to take a preliminary impression. You can actually do the same. You can actually still scan the existing denture, but at this point, I want that papillometer reading because, you know, on the second visit, if we're making base plates and bite rims, I want to contour those bite rims according to the information that I got from the papillometer, and I can contour it correctly. So you'll take on the second appointment, I really like you to take a functional impression and a bite registration in one visit. If you didn't take, you know, the first appointment, you could utilize the patient's existing denture, but if you couldn't do that, then the second appointment, we recommend a functional impression and by registration. Then we'll do a printed try-in, send it back to you for your third appointment, and then everything looks good, we'll mill it and send it back to you for the insertion on the fourth appointment. So we can eliminate an appointment if we didn't have to make that impression and by registration, the functional base plate and by registration. So let's talk about mill design software here. So this software is fantastic. I mean, I'll show you some of the examples in a minute. You know, so the Cad Design Software, you know, is great for this type of denture, and it's a mill denture software, and it's for, you know, full cases, single arch cases, and immediate dentures. And now we're utilizing this for implant over denture cases too. And what they use, they actually utilize the Ivoclar Vivadent tooth library, the Blue Line, Vivadent, and Phenaris library with the same material on a denture tooth card, like you saw with the IPN tooth. The same thing with the Ivoclar tooth. You could either use a tooth card, or you can actually mill a puck, the denture teeth out of a puck with the same material. And I'll show you what I mean. And it's a full arch setup function. Makes it easy for a full arch setup. And we have an extended advanced workflow, which I don't think I'm going to get to today, but that'll be in my advanced course here. But it's a great process. And so the digital tooth library utilizes the Phenaris teeth, the Vivadent teeth, and the Blue Line teeth. And you know all these teeth, the high-end, great wearing teeth. They look great, the aesthetics are great. Or you have the option of just doing full arch. You know, when you're doing a full arch setup, you can mill a full arch or a quadrant arch out of these special pucks that I'm going to show you in a second. So the software allows for complete control to change the shape of the denture teeth when you're milling the denture teeth, and it's important to be able to create the ideal occlusal contacts for single arch dentures against natural teeth. So let's show this here. So this particular photo here, we're bringing those bicuspids into occlusion. There we go. And we can even widen the occlusal surface here. It's great. I love this. It's fun to play with too. It's good. It's like a video game. But anyway, yeah. So just what you can do a lot with these types of the software here. So, and we don't have to do a complete reset when a tooth needs to be removed. So removing molars and premolars is as easy as a click of a mouse, as you can see here. Remove a tooth here. Move the premolar, and everything's done automatically here. So, and it's great. This software is great for immediate dentures. This is one of my favorite things when immediate dentures. So we usually call this model surgery. So we're doing an immediate denture. All we have to do is highlight the tooth in the software, and it's gone. And then we can do some tissue contouring to reduce that bony undercut there on the right-hand side. We can contour that tissue, and we can do a nice immediate denture. It really works out good. And I'll tell you, a lot of the times we're doing immediate dentures, we are getting intraoral scans, and pretty good accurate intraoral scans. If they're missing a certain area, many times it's the immediate dentures are being relined anyway. But I still want an accurate impression. So the pre-prep scan is cool too. It's designed for immediate dentures and simplified by utilizing the pre-prep scan and overlay function, and allows us to set the denture teeth using the existing teeth as a guideline. So this is great for immediate dentures, and I'll show you what I'm talking about here. So this is the existing denture teeth. We're going to use this as a guideline and just come over with a denture setup here. And it's going to, I don't have all the photos here to show you, but you're going to have that full arch setup, and you can adjust it like I did before. So pre-prep scan is great. This is in 3Shape. So we got some good tools to use here. So some of the materials utilized in the mill dentures are something called the ivory-based Cad and the Vivadent Cad. And the Vivadent Cad is the same material that the denture teeth are made out of, only in a puck form. And you can mill out a quadrant, you can mill out 3 teeth, 6 teeth, whatever you want to do. I like to do full arch. That seems to work the best. You can do 2 sections or 3 sections. So I like to do a full arch mill. So, and then the PMMA is the same as the ivory-based material. We talked about that ivory-based injection machine earlier. It's the same material as that, only in a puck form. Physical properties are great, high impact resistance with flexible strength. Accuracy of fit is great. The feedback I get from a lot of clinicians who have been using this material is that they don't even ask for a post hammer anymore because the fit is so accurate. But I like to put at least, maybe I won't put 2 to 3 millimeters, but I'll put a little bit of post ham in here. But it's the deformation after there's minimal to none after milling, which is great. The accuracy is fantastic on these cases. And these are the different shades of the different tooth pucks here, as you can see, anywhere from bleaching shades to D2. And the aesthetics on these pucks are fantastic. I'm going to give you a little test here, and you tell me which is the difference here. I got these teeth here. Half the teeth on the tooth cards here are milled. The other half are the traditional carded teeth. And I'm going to split them down the middle here, in the midline. And you tell me which is milled, which are milled and which are not. So this still surprises me. So, okay, I'm going to give it away. So on the left-hand side, there's your Vivadent Cad. Those are the milled teeth. On the right-hand side, those are the carded Vivadent TCL teeth. So pretty nice aesthetics, though, aren't they? They're really nice. So, yeah, it's lower opacity. The anatomical shape is great on these teeth, and the surface design is fantastic. So real natural-looking teeth. And translucency is great, too, because now they have a different kind of puck where you can adjust the translucency on the anterior teeth, or all the teeth. And it's called the Vivadent Cad Multi. And let me just click here and see if I can show you. Oops, let me go back. Go back here. Let's see. Let's see if this works here. But anyway, yes, here it goes. Yeah, so you can adjust the puck and give for the level of translucency, as you can see here. You want more translucency, you just raise it up a little bit and get more translucency. So this is the Vivadent Cad Multi. which works out great. Let's see how we're doing with time here. Oh, cool. Almost done. Right on schedule. So anyway, yes, that's a great option. And the same thing, you know, we still have to bond these teeth at the denture base, and there's a special polymerization system they use, and it's the Cad bond material, which works out great. And the equipment they utilize is the program PM7. It's a large milling machine, and this is where you mill the denture out. You can see here the photo of the denture being milled. And you talk about the milled denture workflow. When it's, you know, when I mentioned earlier, I like to use the Vivident Cad material, you know, the milling of the actual the denture teeth and in the puck. And so what we're doing, we're scanning and designing, and there's something called the oversized milling process, which it's not completely milled. It's almost like I showed you with the printed denture. It wasn't completely cured. So what we do, we have something called vestibular milling. So we mill the denture, and then we mill the tooth arch, and then we bond it together, and we put it back into the milling machine. And after we use the Cad bond, and we do a fine milling. And when it comes out, the case, really all you have to do is cut off the supports and polish it, and that's it. And you have your milled denture. Total time for milling is about 150 minutes. So, and these are the dentures that I did. This is the final milled denture. Came out beautiful. Look at that. So yeah, so great technology. And you know, now after going through all that, they did come out. It's a little more expensive. They have one disc for one milling, and it's called the Ivotion disc, where we have teeth and the gingiva in one puck. So you have your choices here. A lot of choices. You know, if you want to spend a little bit more, you get the one puck, one disc, one milling. And it's called Evotion, and it's a, you know, it's a shell geometry the way they make these, and it's another beautiful denture. So it really works out well. Can we make a better denture? I think we can. You know, I think, but you know, digital technology, it's come a long way. It's, you know, it's getting more and more popular. You know, and we're going to see a lot more of it in the coming years. So you know, why choose a milled denture? Pretty much the same way we chose the printed denture. Few manual steps, accuracy, the monolithic strength. Actually, when you mill the full arch and the denture puck, they claim it's 8 times stronger than a traditional analog denture, which is pretty cool. And there's your aesthetics, nice aesthetics. I'm going to show you how the fit looks right now. Check out this.
Close, open,
full
close,
upper, full lower.
Tap, tap, tap. Stay closed, and then move your jaw side to side. Just relax, open up, bite down, tap, tap, tap. Again, move your jaw side to side.
I'd be really happy if I was that patient.
Just relax.
That's really nice.
Retention to the lower.
There's suction on the lower.
Very good. Attention to the upper denture. Very hard to break the peripheral seal. You have to go to both sides in order to
There you go.
Get the denture out.
So what a great fit and great, you know, great aesthetics. And this is your milled denture. So with that, I'm going to end this and then get some questions. But artistry through denture technology is what we do. You know, we collaborate for the success of the patient. So really successful cases over the years with these techniques. And we have other courses that we can give to in dentures too. I have other courses I lecture on. And you know, after today, I'm going to take some questions. We still have some time left, so I'll be glad to try to answer any questions you have. But really, thank you for your attention.
Before we jump into the questions, just want to post up Dennis's next webinars, occlusal splints, diagnosis, fabrication, and treatment. While we encourage everybody to register, also want to encourage you to log on early. Our maximum capacity is 500 and we already have over 650 registrations.
Wow.
But rest assured, if you cannot get on live that evening, we do record our educational sessions. So a copy of the recording will be emailed to you directly. So with that, I'm going to jump straight to the questions.
Right.
We have one: how to achieve retention in the lower denture?
Good question. Good question. Yes, lower dentures are tricky. Lower dentures are tricky, especially when you have a large tongue area. So I found that with lower dentures, I really like to have a full roll. Good border molding, full roll, and contour that denture, especially even on the buccal side, where actually the cheeks can actually rest along that buccal ledge, and that helps keep the denture in. On a lower denture, it's real difficult. Unless you and soft liners help also with lower dentures. You get the proper soft liner material. I like something called it's a soft liner called VersaAcryl, which works out great. It's from Keystone Industries, but there's other ones out there from a lot of different soft liners out on the market. But I love a denture that has suction like you just saw. I mean, it's amazing. You don't see that too often. But pretty much the contour, if you're going to get a denture, just make sure it's contoured correctly on the lingual and the buccal, and you have a good full roll on that denture there. So, and not overextended, but just something that's going to help it with the retention.
Thank you, Dennis. And Dr. Vanessa Dawson, I'm clicking to unmute you if you still want to ask your question live. Dr. Vanessa Dawson. There we go.
Yeah.
Dr. Dawson, it looks like you are unmuted. Is your microphone on? Oh,
Okay.
Her hand went down. Yep, technical difficulty.
Okay,
It's
no
okay,
problem.
Dennis, we have plenty more questions. So here we go. You
All
ready?
right. Hope I can answer them. Pressure's on. Pressure's on.
The pressure is on. Like CAD/CAM crowns, how common can this digital full denture technology, can it be taught to students in dental schools in the US and worldwide? It seems to be a long learning curve. Very interesting lecture. I always wanted such technology as a dentist who had a huge patient base of dentures, but is it economically viable option for low-income patients?
Yes, it is. I'm probably going to answer that last question. Yes, we actually have a denture now. It's a printed denture. We call it, and I don't like to call anything economy, but it's an economy denture, which is affordable for low-income patients here. So we can do those low income. As far as cost effective, there's different systems out on the market, and all, as far as teaching these systems in school, I'm actually helping putting together digital curriculums for a few universities now. And so it is teachable. It can be, it takes a while to learn, so because you really have to know the science behind what you're doing. So they're still teaching the traditional techniques and then adding the digital technology later on. So, I believe right now it's affordable. I mean, it's nothing. If you want to invest in the scanner, that's the only thing you're going to be paying for. But everything else is done by us in the laboratory, unless you have a printer in your office. The other night I lectured with a dentist for dental economics, and he has 3 printers in his office, and all he does is dentures. So he loves it. So after a while it pays for itself, but it is teachable, and I think it's the way of the future. And the real demand came during COVID here from a lot of these universities wanting to put together programs. One of them is NYU, helping out with a digital partial program now, and it's going to increase. It's still evolving, but I feel like that's the technology of the future.
Thank you, Dennis.
Thank you.
And what type of impression material, in parentheses, dark blue, was used for the final impression?
Oh, okay, that was okay. Let me think now. Oh my God, that's an old photo. There's a couple. This GC America has a great impression material. Reyes Culture has great impression materials. There's a company out of Milwaukee. I think that's what it was. It's called IS 2000. And you can go online to look at this. And a lot of the impressions you see from them, even the by-registration material, IS 2000, they're out of Milwaukee. And that's another good company. I'm not too sure exactly which material was used on that, though. You have me thinking now because it's such a long time ago that photo was taken. But just get a good company, a good reputable company. All these major companies have decent impression materials. Don't get an economy off name brand, because I've seen it. I've seen cases come in with so many pulls, especially on partial dentures, voids, pulls, and inaccuracies, the wrong type of compression. So a good PVS impression material is what you want to look for, and a good reputable company.
Well, the same person's going to get you thinking more, Dennis, because they're curious what material was used for the functional impression.
Oh, that's that functional impression. That was, okay. So that functional impression, that was taken a while ago. That was a case from, we did a course at UCLA, and it has to be over 10 years ago. So I really can't answer your question on it. I'm sorry. I can try to find out with that. So I can ask, that was a course a long time ago that we had at UCLA. And actually this picture that you see on the screen here, this is the patient that was at UCLA. This is the patient right there. So this is Dr. N, Eugene N from Germany, who invented the physiodentist denture tooth. So, and that's a great story there. This is, this patient had so many problems with different dentures, various dentures, and did the functional impression technique with her. And we did everything pro bono. We had about 20 to 25 dentists from around the country come in. We sat in a separate room, and Dr. N was working on the patient. And the last day there, we were there, and the patient came in. She brought an apple with her in a hand, and they asked her, what do you bring? What'd you bring an apple for? And we were all in another room. We could see this on a screen, So Dr. Ann put the dentures in, and she says, I brought an apple because I haven't had an apple or anything really firm for years. I couldn't eat with my previous dentures. So we gave her a 33-degree cuspal inclination with posterior teeth, and then we gave her physiodentist anterior teeth. And with Dr. N put the dentures in and walked out of the room. 20 minutes later, we all walked in the room there, and we met the patient, and she had the apple half eaten, and the dentures fit perfectly. So that functional impression and the combination of everything this doctor did, it was really, really, really a great experience. So I always forget to tell that story.
Now, Dennis, every time I eat an apple, I'm going to think of this denture case.
Yeah, particularly that case, and that was such a great course there. And I think that's pretty much the last time he was here. He's in Germany. He has a great book on occlusion. If Dr. Eugene End. It's in different languages, so you can get it in English. I have a nice autographed copy, but it's a great on physiological centric occlusion. Really good book. So.
Wonderful, thank you. As a Canadian dental student who's graduating soon during the COVID times with limited experience regards to dentures, what advice would you offer to learn the digital aspects, as in any CE courses or programs to enroll in?
Okay, that's good question. And a lot of these companies now have, all the major, and I'll go through, I'm not trying to be biased here or anything. I'll just name some companies. Ivoclar, Dentsply has some great, Stern Gold, a lot of great, even Vita. I mean, they all have great courses for clinicians, and even, residents, they have courses. And even we give these courses at DSG, and we can help you with that, so, and we have offices in Canada also. So I would utilize that information, capitalize on these manufacturers too, because a lot of online courses, and now they're starting to have more, in-person courses. I know things are still tough with COVID, and as far as getting in person, but really, I think it's the technology is there. It's only going to get better. So that's my advice: is just try to tap into the information's out there from the dental manufacturers, because they really give great support. On these types of courses.
I have reposted Dennis's contact information and also a link to dentalservices.net/edu on that page. Right as you scroll down halfway through the first click of it, it says watch the recordings. If you click through there, it takes you straight to our YouTube channel called DSG Education, where you can watch all, I think there's over 60 courses on there as of today. So we have another medium or heavy body should we use for the final impression?
I would recommend a full arch case, fully intentional case. I'd say medium body. So I like to, I have had some heavy body material, but I just question sometimes the compression on, and believe me, a lot of people will differ with me but I'm just looking at the success rate of the dentures that I've done over the years and work with clinicians on, and medium body seems to work really well. And if you're doing a wash impression, it's not that much resorption has happened, then I like the light body material, so, it's just got a good quality material.
Thank you, Dennis. And Dr. Mark Spector, you are unmuted to ask your question live.
Hi, can you take traditional impressions and still get milled or printed dentures?
Yes, doctor. That's a great question, and that's what I like. I actually like a good traditional impression and scanning that and getting the information because, like I said, we're still having some difficulty with fully edentulous scans, you know, and that's a good point there. I love.
Will we have access through the labs to finding out pricing on these things?
Yes, you would. Yep. As far as a scanner or just the cost of the denture.
The cost of the denture.
Yeah. Okay. You know, so a lot of people ask about the scanners too. Yes, you can. Yeah, you can contact me through that. You know, if you want, and I can give you some pricing through my email. I'll show you my email.
Yeah, you gave us all these great choices, and now I don't know what to do.
Okay. I confused you. I'm sorry. No, there's a lot of good choices out there. But yeah, feel free. This is my email address, and you know, feel free to email me, and I'll even get on the phone with you. I'll talk to you, and we can walk through this, some of the best you know, options for this type of denture.
Thank you.
Thank you, doctor. Appreciate it.
Thank you. Next question. Please comment on ABE's SEMCD, suction effective mandibular complete dentures.
Okay, just say that one more time. That's a tricky one.
I just hit done. Hang on one second.
Okay, sure.
Suction effective mandibular complete dentures.
Suction effective mandibular. I'm not too sure where you're heading with this. I'm not too sure, but I know we talked about those suction cup dentures earlier. But you know, I mean, I could just talk to what I know about the mill dentures. I'm seeing a better fit on the lower denture with a mill denture compared to any other type of lower denture. And you saw that fit that we saw earlier with that mill lower denture. It almost has suction on it. You know, so but I'm not too sure where you're going with that question there. But I hope I answered in some way. And if I don't, you know, if I don't answer your question, just email it to me and I'll get the information for you. Thank you.
Great, thank you. If you could comment on using a radiograph of the, I'm not going to, angulation of the glenoid fossa to help determine what degree of posterior teeth to use. The steeper the angulation, the greater the degree of posterior tooth.
Right. Yeah, I mean those are the guidelines I followed over the years, which what you just mentioned, and that you know, the size of the ridge and the cuspal inclination. You know, hopefully there's enough room. You know, sometimes you know the ridge is so bony and huge and big. You know, we have to grind those denture teeth down to nothing, and it just defeats the purpose. You know, so yeah, I use as a guideline. That's a great point there. You know, and the size of the ridge. And I actually had, you know, when I made my mother-in-law's denture, you know, she had a flat ridge. And which, you know, I was using less degree of teeth on the flat ridge and it wasn't working. He wasn't able to eat. And finally, I gave her a smaller physiodense tooth or 33-degree cuspal inclination, and she was able to eat. It was amazing, the function that was happening. She had a flat ridge. She was 6. She couldn't get implants, but you know, really proved to be a real functional denture. But that only adds to the planning of the case. What you mentioned, I mean, just adds to the successful planning of the case.
And somebody jumped in regards to the Dr. Abe's SEMD denture. They said they mean Dr. Abe's lower suction dentures. Does that ring a bell?
No, no, it doesn't ring a bell. Yeah, I'm sorry. Yeah.
The next question. HIP plane, I think this is somebody talking about a reference from a question earlier, is useful for digitally designed dentures as the occlusal plane and has been found to be coincident to the HIP plane triposodian with 2 hamular notches and the inclusive papillar. It is an intraoral reference for establishing an occlusal plane when the extraoral reference Camper's plane is not available.
Okay,
so
good.
They were commenting.
That's great. Okay, great. No, that's great. That's a good comment there. I like that. Yeah. So and so you know they're constantly upgrading this software too. You know, between the first, I remember when I first saw this software, it was just a virtual articulator, and now there's so many different adjustments you can utilize, and even with the Gothic Arch tracing device, you know, with the advanced workflow on these digital dentures. with the Gothic Arch tracing device, and they have something almost like a virtual face bow also that is utilized, and all that information is put into the software. And you talk about a good, accurate, occlusal record there. It's amazing. So and it's going to get better and better. So that's why I'm excited about it. It's great technology. But thank you for that. I appreciate that. Yeah.
Thank you. And then we've got a long one. Please comment on the following. Using golden proportion values, one can take the allometer value and will know that the width of the maxillary central is 25% of the total allometer reading. If one knows the width of the maxillary central, then again, using golden proportion, one knows the length of the maxillary central. If one knows which anterior teeth to use, can then use the corresponding posterior teeth. Oh, they were commenting back.
Okay. Yeah, no, that's great. Yeah, in golden proportions, it's funny because I did a course about 3 years ago in a laboratory here in New York, and we had the whole removal department did a setup course, and the crown and bridge technician, well-known technician, and he goes, Dennis, we follow everything with golden proportions. Can you apply this to dentures? I said, yeah, you can. So that's a really good comment right there. And there's so many aspects. People don't realize all the aspects of removable edentulous technology that you can utilize, for successful cases. And I was only able to mention a few tonight. And I've been doing this for 42 years. I still learn from these courses, and I still learn from people. I traveled around the world teaching and learning. It's amazing. So I love the feedback that you're giving tonight and the questions. I really appreciate that. Thank you.
Great. And I am not seeing any more questions or hands. So thank you, everybody, for joining us here this evening. Again, Dennis has another course coming up on Tuesday night, May 4th on occlusal splints. Hope to see you there, or in upcoming webinars proceeding in the future. And don't worry, I will poke him to make an advanced course on the excellence for denture technology. So stay tuned, more coming soon. And with that, I turn it over to Dennis to close us out this evening.
All righty. Thank you, Jessica. I really appreciate it. Thank you, everybody, for joining us tonight. And 2 hours, we packed it with information here. And I just want to I hope all of you had a positive learning experience today, and maybe apply your knowledge and expertise in a positive way, in a way that will enhance your careers and so forth. So have a great day, and feel free to email me with any questions. And it was great to have you here tonight. Have a great night now. Thank you.